You're welcome to my channel. Thanks for visiting. Today, I'll continue on infective endocarditis, focusing on the modified Duke criteria. But if you haven't subscribed to my channel, please kindly do. If you are subscribed and you are visiting again, I'm saying a big thank you. Without further ado, let's go. When it comes to the diagnosis of infective endocarditis, the hallmark of infective endocarditis will be the inflammatory changes in valvular tissue at the attachment of the vegetation. And of course, there will be fever as long as there is bacteremia. But if you want to know more about vegetation, which is an unwanted mass, though that is made up of fibrin, platelets, and bacteria glued together, please kindly click on this very link. This link will take you to further explanation on vegetation formation, where it is formed, and possible complications. Generally, if anyone is concerned about infective endocarditis, we want to know the culprit, that is the causative organism involved. The diagnosis of infective endocarditis and its complication may take us through 3 different areas. Clinically, we'll take history, the signs and symptoms, we'll do physical examination like peripheral stigmata through the hands, remember genital lesions such as nose and so on, and of course we'll review the risk factors. Then we must get to the lab. We want to know the exact bacteria responsible. Fungi could be responsible sometimes, and then it could be culture negative infective endocarditis and so on. Then that wise, we will have serology polymerase chain reaction done. Cardiac enzymes could be assayed to rule out myocardial infarction. And then we'll go for radiological study. Topmost will be echo, and of course, cardiac CT. And as the case might be, we can embark on the rest. But Duke criteria is pretty important. The Duke criteria was established in 1994 by Dr. David Durack of Duke University. The revised version came up in the year 2000. The topic today is modified Duke criteria. Then the question is, modified? Has Duke criteria been modified? The answer is yes. And what is new and what has been taken away? Okay, 2 things have been added: Coxsackie bonnetii and possible infective endocarditis criteria. So what happened here? Here, it has now included positive serology for Coxsackie bonnetii as part of the major criteria. Minor echo criterion has been removed. And then possible infective endocarditis criteria has been clearly stated. Modified Duke criteria, the pathological criteria. Here we'll have 2 points. The pathological lesion is revealing vegetation or intracardiac abscess. Now, that will be demonstrated on histology. And it is possible to have microorganism demonstrated through histology of the vegetation or intracardiac abscess. Of course, we'll culture that also. We've just gone through the pathological criteria where histopathological study of vegetation and intracardiac abscess will become pretty helpful. Now, let's go through the clinical criteria. Here we'll have the major and minor. Now, the major criteria. Here, let me go to the first criterion under major. The second one will be about echo, but this is about positive blood culture for infective endocarditis. And that could come in three different forms. Either A, as typical microorganism has been picked for infective endocarditis from two separate blood cultures that must have been taken at least 12 hours apart. If that is the case, then that is a criterion under major. Or it could be still under blood culture, it could be that there's persistently positive blood culture for organisms that are contaminating the skin. And that is done in 3 to 4 separate times, and the blood cultures are positive, with first and the last sample taken at least 1 hour apart. If that's the case, you can take that as criterion 1 under major. Or lastly, a single positive blood culture for Coxsackie bonnetii or antiphase 1 immunoglobulin G antibody titer that is greater than 1 to 800. So if you're able to get either A, B, or C under positive blood culture, then you are fine as having one major criterion. The second criterion under the major will be evidence from echo. We are going to have transthoracic or transesophageal, but mostly we'll start with transthoracic and then have transesophageal, or you go straight to transesophageal echo. But that is not the topic for this moment. For now, under Duke, echo evidence of endocardial involvement is a major criterion. Then that could be in 4 different ways. Echo could show us vegetation on the valve or endothelium. That is acceptable. Or the echo is showing abscess. Or the echo is showing prosthetic valve dehiscency, or there is new valvular regurgitation. If echo is showing any of this, that is a major criterion. Now, the minor criteria. Number one criterion here will be fever. The fever here is going to be greater than 38 degrees Celsius or 100.4 degrees Fahrenheit. If that is it, that is a minor criterion. Another criterion that is minor is whether the individual has some risk factors, like the use of intravenous drug, or there is presence of prosthetic heart valves. If you pick that, that is a criterion, but it is under the minor one. The third criterion under the minor will be that the blood culture is actually positive, but is not meeting the major criteria for blood culture. So the blood culture that is positive is outside of the major criteria for microbiology or serological evidence. Then another one, which will be the fourth criterion under the minor, will be immunological phenomenon. In that case, you can pick raw spots through fundoscopy, although not pathognomonic, because it could be found in other disease conditions. You can pick Osler's notes, which is pathognomonic of infective endocarditis through the hand. You can find rheumatoid factor, that is pointing to autoimmune condition present, and glomerulonephritis. The last criterion under the minor would be vascular phenomena. Here you can pick Janeway lesions on the hand, conjunctival hemorrhage through the examination of the eyes, intracranial hemorrhage in the brain, mycotic aneurysm. I have a separate presentation on mycotic aneurysm. Then septic pulmonary infarct or major arterial emboli. That will form the vascular phenomena under the minor criteria. How can this help us to make definitive diagnosis? Definitive diagnosis could be made if you are going through the pathological criteria as vegetation or intracardiac abscess that is demonstrating active endocarditis on histology. If you go through that, you are making a definitive diagnosis. Or another way under pathological criteria is that you have demonstrated by culture through histology that the vegetation and or intracardiac abscess is harboring the microorganisms responsible for infective endocarditis. Now back to definitive diagnosis under clinical criteria. If you were able to pick two major criteria, you are fine to make the diagnosis. If you are unable to get that, but you were able to get one major with three minor, you are fine to make the definitive diagnosis. Or you cannot meet the major criteria through the echo or through the blood culture, but the minor criteria, you can pick 5 of them at once. Then you are fine to make definitive diagnosis under clinical criteria. Like I said in the beginning, that when we're talking of modification, we need to say what is new. Possible infective endocarditis can now be one major with one minor. If that is the case, that is a possible infective endocarditis. Or you're unable to meet one major, one minor, but you can find 3 minor, then it is possible infective endocarditis. You are fine to reject infective endocarditis as the possible diagnosis if the clinical and pathologic criteria are not met. Then also you can reject it if the clinical signs and symptoms are resolved or resolved completely in less than 4 days of the onset of antibiotics therapy. With that, we'll expect the treatment of infective endocarditis to take weeks, as long as 6 weeks. But in less than 4 days, the use of antibiotics has cleared all the signs and symptoms. It is not likely that you are dealing with infective endocarditis. Also, you've had the postmortem or autopsy done, and there's no evidence of infective endocarditis at postmortem or autopsy after the use of antibiotics for less than 4 days. Then you can conclude the individual has not been killed or has not died, due to infective endocarditis. And lastly, you have already made up your mind and you've concluded and you are accurate that you have alternative diagnosis. Then that is the end of the story with infective endocarditis. With that, I've come to the end of this short presentation on modified Duke criteria. That has remained a strong weapon to making definitive diagnosis of infective endocarditis for many years. Thanks for listening. Remember to subscribe. I will publish more presentations after these about how to make accurate diagnosis of infective endocarditis. going through microbiology, echo, serology, and so on. Thanks for listening once again. Please remember to subscribe. I appreciate it.